Greetings, everybody. Hello, my name is Mike Willett at the Intertribal Council of Michigan. Greetings, everybody. My name is Mike Willett at the Intertribal Council of Michigan's National Native Network, and welcome to the National Native Network webinar series on cancer risk reduction in Indian country. This webinar is titled Tobacco Control and American Indian Cancer Policy. This technical assistance webinar is being hosted by the National Native Network, which offers technical assistance and resources for commercial tobacco prevention and control throughout Indian country, and the Indian Health Service Clinical Support Center. Your presenter today is Donald K. Warne, MD, MPH, Associate Professor and Chair of Department of Public Health. Dr. Warne earned his Doctor of Medicine in 1995 from Stanford University School of Medicine in Palo Alto, California. Dr. Warne has also earned his Master of Public Health from Harvard School of Public Health in 2002, with his major area of study in health policy and management. Dr. Warne is the Senior Policy Advisor to the Great Plains Tribal Chairman's Health Board. He is a member of the Oglala Lakota tribe from Pine Ridge, South Dakota. Dr. Warne received his MD from Stanford University School of Medicine and his MPH from Harvard School of Public Health. Dr. Warne's professional activities include member of the National Board of Directors for the American Cancer Society, member of Minority Affairs Section, and Association of American Indian Physicians representative to the American Medical Association, member of the Advisory Committee on Rural Health and Human Services for the U.S. Department of Health and Human Services, and a member of the National Institute Review Board of Indian Health Service. We are pleased to offer continuing education units for participants in this webinar. No commercial interest support was used to fund this activity. This activity is designated 1 contact hour for nurses. To obtain a certificate of continuing education, you must be registered for the course, participate in the webinar in its entirety, and submit a completed post-webinar survey. By the end of this webinar, participants should be able to identify patterns of American Indian tobacco use, identify patterns of American Indian cancer mortality, recognize the role of healthcare professionals working with tribal leadership in creating tobacco control policy. Please type questions into the question box on the lower right-hand side of your screen. Questions will be answered during the last few minutes of the webinar. And now at this time, I bring to you Dr. Donald Warne.
All right, can you hear me okay?
I can hear you fine, sir.
Okay,
and
very
I just
good.
handed over to Paul.
All right, thanks very much, and thank you everyone who's attending the webinar. Again, I'm Don Warne. I'm originally from Kyle, South Dakota on the Pine Ridge Indian Reservation. We'll be talking about tobacco control and American Indian cancer policy. And just to give you a brief background, I am a family doctor and I've worked in a number of areas in American Indian health. And what I've found in my own experience, and I'm sure many of you have had similar experiences, is that the majority of issues that we deal with are preventable in terms of health issues, chronic disease, et cetera. So we'll be focusing on tobacco control and American Indian cancer policy and looking at what the role is for healthcare professionals and tribal leaders to try to prevent these issues from occurring. Well, again, I'm originally from Kyle, South Dakota on the Pine Ridge Indian Reservation, and in many ways, Pine Ridge, South Dakota is seen kind of as the epicenter of health disparities for American Indians nationally. We have terrible disparities on a number of fronts, including infant mortality and cancer, heart disease, diabetes, injury-related deaths, et cetera. And one of the challenges is, of course, that this is preventable, and one of the outcomes of all of the disparities is that we have very early age at death. The most recent data I saw from Pine Ridge is that the average age at death for men from my community is now down to 48 years of age. So in many ways, third world health conditions. Where I'm working currently is at North Dakota State University in Fargo, and we have the only Master of Public Health in the nation in which students can specialize in American Indian public health. So this is the, I'll show a couple of pictures of my hometown, Kyle. This is the Food Stop Cafe. And I think what they've learned here is that you can bread and deep fry just about anything and serve it for lunch. And we are in a food desert in most of our tribal communities in the Northern Plains. And a food desert is essentially a location where you have difficult access to healthy food choices. Right across the street from the cafe is the gas station, and the gas station also doubles as a grocery store. So we wind up purchasing things at the grocery store or at the gas station that are usually in a plastic bag or in a can, and typically it's processed foods and not the healthiest choices. And we also have some access to fruits and vegetables, but there is a concept in public health in impoverished communities called a poverty tax. And a poverty tax is not a real tax per se, but it is a circumstance in which people who live in impoverished communities pay more money for healthier food choices like fruits and vegetables. So even if we have access to fresh fruits and vegetables in this region, we have to pay more money for those things. And we're seeing strong associations now between poor diet and obesity and poor cancer outcomes as well. So when we combine smoking and poor nutrition, we have all kinds of challenges in terms of chronic disease disparities. This is a picture of one of my relatives in Pine Ridge, and you can see he has an amputation from poorly controlled diabetes. And in our community, we do have a program that will build a ramp for people who have wheelchair needs. The challenge with that is that we don't invest in healthy food at the front end. We don't invest in preventing chronic disease. But once you have an amputation, we'll build you a ramp. So we tend to invest in people's health after they become sick and after they become disabled. And it really is backward. And we need to focus on primary prevention efforts. And we all have a role in that, whether it's through tribal leadership or the provision of health services and promoting smoking cessation or preventing smoking in the first place. Well, I'm sure most of us are aware of the Indian Health Service areas. There's 12 areas of the Indian Health Service. And I apologize to my Alaska Native brothers and sisters. I know Alaska is not off the coast of California, but this is the best map that I could find. And one of the things that we see across Indian country is tremendous regional differences in health status and health outcomes and health behaviors. So for example, in the Northern Plains, kind of the northern tier of the Indian Health Service, Great Plains area, Billings area, Bemidji area, we see higher rates of cigarette smoking, and then not surprisingly worse outcomes for cancer. And I used to work as a primary care doctor with the Gila River Indian community in Arizona, and they have very high rates of diabetes, but relatively low rates of cigarette smoke. And one of the outcomes is that their cancer death rates are not as bad as other regions of the Indian Health Service. So I think it's important to acknowledge up front that there are regional differences and there are cultural differences across Indian country. So it's not one homogeneous population. We have a lot of diversity in Indian health. So let's look at the cancer death rates. And this was from the American Journal of Public Health supplement published in 2014 that was focused entirely on American Indian and Alaska Native mortality rates. If you have not seen that, you might want to get a copy of it. It's, I think, the best source of data that we have for American Indian and Alaska Native mortality. But looking at cancer death rates, looking at all causes of cancer, you can see that in the Northern Plains, we have by far the worst cancer death rates as compared to the white population. Excuse me. So we see a tremendous disparity in terms of cancer death rates for American Indians in Northern Plains, Southern Plains, and Alaska. We can see Pacific Coast is about equal with the white population. And interestingly, in the East and in the Southwest, American Indians actually have lower cancer death rates. So if we try to aggregate national data, we're not really getting a full picture of the disparities in issues like cancer. Well, why is it that in the Northern Plains and Alaska we have such terrible disparities in cancer death rates? And Much of that is due to disparities in commercial tobacco use and smoking. So we can see in the northern tier of the U.S., states like Wisconsin, Nebraska, Minnesota, South Dakota, and North Dakota, the smoking disparities are tremendous. It's more than double for the American Indian smoking rate compared to the non-Indian smoking rate. And we can see it ranges around 50 to 56%, and that's statewide data. We've actually examined some of our reservation communities, and the adult smoking rate is well over 60%, approaching 80% in some of our reservation communities. So we've kind of created a circumstance in which the social norm is that adults smoke cigarettes, and that puts us at tremendous risk for early death from cancer, heart disease, and stroke. And if you combine commercial tobacco use with diabetes, that actually is an 11-fold greater risk of mortality from cardiovascular disease and stroke. Well, one of the important things to remember is that traditional tobacco is not the same as commercial tobacco. And many of our tribes, particularly here in the Northern Plains, we had traditional tobacco, which really was a blending of herbs. The picture on the left is a picture of chinchasha, which is what we call traditional tobacco in Lakota. And it's primarily red willow. And there's actually medicinal effects of traditional tobacco, which is very different than commercial tobacco. So when we have programs that focus on tobacco-free environments, we need to be very specific that we're talking about commercial tobacco-free. And if we say smoke-free public places or tobacco-free sites, in many ways, for some of our communities, that's actually culturally incompetent. We have to be very specific that we're talking about commercial tobacco and not traditional tobacco. Well, let's look at some of our disparities. And if we look in North Dakota, the graph on the top here shows American Indians by age group. And you can see that by far, there are many more young American Indians as compared to older American Indians. That's very different than the non-Indian population in North Dakota. So the pattern we see in North Dakota is similar to other states in that we have a much younger population. And that's because both our death rates and our birth rates are higher than other populations. So we actually, unfortunately, have relatively few elders who are 70s and in their 80s compared to the rest of the population. So we have higher rates of death, but we also have much earlier age at death. And this is creating a circumstance in which our population is very young, but also an opportunity to try to prevent health behaviors that can lead to excess death. So if we think about what are some of the causes of death, and we look at the data right here from North Dakota, we can see the deaths and age-adjusted death rate by cause for American Indians compared to the rest of the population. And just all causes, you can see 6,589 is the rate compared to 687 per 100,000 population in North Dakota. So our death rate is approaching 10 times greater. That's just remarkable how much early death we endure as tribal populations. And you can see how much of this is smoking related. We have heart disease, adjusted death rates significantly higher. Same with cancer, stroke, COPD, even diabetes and influenza, which are impacted by cigarette smoking. We have significant disparities in average age at death, but much of this is actually in the form of commercial tobacco-related illnesses. So there's a lot of important work to do in public health, and we can prevent significant amount of morbidity and mortality by focusing on tobacco control. If we look at the average age at death in North Dakota, these numbers are just remarkable. So overall, it's 54 for American Indians in North Dakota compared to 76 for the rest of the population. And that's a difference of 22 years in average age at death. So in many ways, we have third world health conditions right here in the heartland. And I've seen similar data for South Dakota, and our average age at death is much younger for American Indians compared to the rest of the population. But if you look at specific cause, again, much of this is commercial tobacco related. Much earlier age at death for heart disease, cancer, stroke, COPD, diabetes, pneumonia, and influenza. You can see the pneumonia and influenza, 65 years of age versus 83 for the rest of the population. So tremendous disparities, and again, much of it linked to commercial tobacco use. So I'm the chair of the Department of Public Health at North Dakota State University, and in addition to our American Indian Public Health track, we have another track called Public Health and Clinical Systems. And there's a broader movement, generally speaking, looking at how we can better integrate public health principles and medical care. And this is something we need to focus on in Indian country because so much of our medical related expenses are from preventable causes. So if we think about cancer control from this model, we can look at the public health interventions like primary prevention, trying to prevent people from smoking. We also know that obesity is linked to several forms of cancer. So if we're trying to prevent obesity, then we're actually working to reduce medical costs and improve outcomes. So we think about our public health services like community engagement and tobacco prevention, health education and promotion, obesity prevention, and screening and access across the board. But there are some medical interventions that are actually public health interventions. So for example, tobacco cessation therapy, if we're using medication to help people quit smoking, that's actually a public health intervention because we will decrease exposure to secondhand smoke. Also, if we're treating obesity, that is a primary prevention effort for obesity-related illnesses like diabetes and heart disease. So where public health and medicine meet is in that screening arena where we try to link people to necessary services like cancer screening, for example, or screening for tobacco use and appropriate treatment to recover from tobacco addiction. On the medical side, of course, that's where, from a cancer perspective, we diagnose and stage cancer. So the treatment, once we have our diagnosis of cancer, could include multiple types of therapies like surgery, radiation therapy, or chemotherapy. And what's needed, of course, is patient navigation and care coordination in that process. That's another area where we can see much room for improvement in Indian health. So our goal, of course, is to excise or remove cancer by surgical methods and promote survivorship and ensuring that people can survive from their cancer treatment. And the linkage again to public health is that the earlier at which we can diagnose cancer, meaning earlier screening as well, we tend to see better outcomes. But once someone is treated and they are a cancer survivor, and we might be able to eliminate cancer within the individual at a given time frame, that does not mean that public health efforts are done. For those individuals who have had cancer, they are at very high risk for recurrence. So we still need to engage the public health sector to ensure that cancer control is much more complete. Now, of course, we don't always have good outcomes. So if we have a circumstance where someone will not survive, and unfortunately for American Indians across the board, we have worse survival from cancer than other populations. One of the areas that's particularly concerning, and it is linked to tobacco use, is colorectal cancer. And because of colonoscopy and other screening modalities, we've seen mortality rate from colorectal cancer decrease across populations in the United States, except for American Indians. We still have increasing or plateaued survivorship from colorectal cancer. But on the medical side, we need palliative care, pain management, symptom relief, etc. And from a public health or community health perspective, we need to promote family support, social work, and hospice care. So you can see how public health and medicine need to work in a coordinated fashion to have effective cancer control. And the role of tobacco prevention and cessation is throughout that entire process. So one of the classes that I teach here at NDSU is American Indian Health Policy. And one of the questions I ask the students is the following: do people have a legal right to health care in the United States? Are people born with a legal right to health services? And the answer to that, unfortunately, is no. People are not born with a legal right to health care. We've made the decision in this country that if you want health services, you either have to pay for it, or you have to qualify for public assistance programs like Medicaid, or you have to be a veteran or other types of qualifying categories. And this is true for everyone except American Indians. We're the only population born with a legal right to health services. And that's based on our treaties and a number of other legal bases. And we have to remember that even though we have a legal right to health care, we're not getting adequate services. So there's about $3 trillion spent every year on healthcare in the United States. To put that in perspective, $3 trillion is 3,000 billion spent every year on healthcare. Yet prior to the Affordable Care Act, we still had over 45 million uninsured people in 2010. Now, since that time frame, since the implementation of Affordable Care Act in 2010, we now have over 18 million newly enrolled people in Affordable Care Act insurance, whether it's Marketplace or Medicaid Expansion. And we know that access to health services correlates directly with survival. If you have access to health services, you live longer than if you do not. On this particular slide, the graphic on the left is right from the Indian Health Service website. It shows a legal basis for federal services to American Indians and Alaska Natives. And on the right, this is one example of many hundreds of treaties that were signed between the tribal nations and the federal government. This example is with the Potawatomi Nation in 1846. And it's in very fine print, but at the bottom you can see the wording states, and the United States giving at the same time promise of all proper care and parental protection. So this is typical wording in many of our treaties, promise of all proper care and protection. And have American Indians received all proper care and protection? And the answer is no. So in many ways, the federal government is in breach of contract because we have a legal right to these services. It's been proven repeatedly in multiple areas of law, yet we are not getting adequate services. So let's look at the Indian health system to try to get a better understanding of how we can improve care coordination and access to services. The Indian Health Service actually used to be called the Indian Health Program, and it was housed in the BIA, in the Bureau of Indian Affairs and the Department of Interior. In 1954, there was what was called the Transfer Act that moved the Indian Health Program to the Public Health Service. And Indian Health Service in its current form started in 1955. Well, the world of medicine was very different in 1955, and this is before HIPAA compliance, before JCO accreditation, before Medicare and Medicaid. So the world of medicine was quite different in this time frame. In 1975, that was the passage of Public Law 93-638, which is the Indian Self-Determination and Education Assistance Act. So that's a law that allows tribes to take over federal services, whether it's IHS or BIA programs. So now actually the term 638 has become a verb in Indian country. So we're going to 638 the hospital or the clinic. And in Indian country, we kind of speak in our own code in many ways. Well, in 1976, there was the passage of the Indian Healthcare Improvement Act, and it lasted for 12 years, and it needed to be reauthorized in 1988. So in 1988, that was the first time that IHS and tribes could bill Medicaid. It was based on the reauthorization and the amendments to the Indian Healthcare Improvement Act in 1988. So now we have a very complex health system in which we have IHS services at the federal level, 638 health services at the tribal level, and Medicaid programs at the state level. So 3 levels of government, and caught in the middle of this complex web of services is the American Indian healthcare consumer, or the client or patient. And when we're talking about cancer control, quite often we have to refer people outside the Indian health system into the private health sector because we typically do not have cancer specialists or oncologists within IHS or tribal programs. So at any given time, the oncology groups that Indian Health Service contracts with could be different than the oncology groups that Medicaid contracts with. So we have a very complex system, and the challenge is that we typically do not have case managers or care coordinators that overlap all 3 systems and all 3 levels of government. So there's much work to do in terms of policy coordination strategies to ensure that when an American Indian healthcare consumer has cancer, that their care is well coordinated and delivered in a timely fashion. Unfortunately, that does not always happen. One of the major reasons for that is underfunding of the Indian Health Service. This is the 2012 numbers, and you can see Medicare about $12,000 per person per year. Veterans, about $7,000 per qualifying veteran. It's interesting, the VA always talks about underfunding of the VA system, but look at IHS for medical care, about $2,900 per person per year. So in 2014, the numbers are very similar. We actually were able to contain some costs in Medicare, much of that due to the Affordable Care Act. So it's still now just a little under $12,000 per person per year on Medicare. Veterans is now over $7,000 per qualifying veteran per year. Medicaid about $5,500, and you can see for Indian Health Service now about $3,100. So we have seen some improvements in the overall budget for Indian Health Service, but still terribly underfunded relative to other federal health systems. And when you look at our disparities, we probably need not to be just equal, but actually even more resources than the typical patient population. So how can we address this in the framework of tobacco control and cancer control within Indian health? Will the Affordable Care Act improve American Indian cancer control? And some of the things to consider is that American Indians and Alaska Natives face some of the worst health disparities in the nation. However, there are significant regional differences in cancer disparities. And there were several provisions in the Affordable Care Act that address health insurance challenges. For example, insurance companies could say, well, you had a pre-existing condition, therefore we're not going to pay for health services to address that pre-existing condition. So even though we had many people uninsured, the premiums were increasing significantly and insurance company profits were soaring. One of the things to remember is that IHS does not have the resources to address the cancer burden. So we have to be dependent on the private sector, and that's where we use CHS is Contract Health Services. The name has now changed, as most of you probably know, to Purchased and Referred Care. So one of the things to keep in mind, IHS is not insurance. However, we do have the opportunity to engage insurance with IHS and tribal programs. So the Affordable Care Act, Title II is Medicaid and CHIP, and the Indian Health Care Improvement Act was actually added on to the Affordable Care Act and permanently reauthorized in 2010. In terms of Title I and Title II, Title I of the Affordable Care Act looked at affordable and available coverage and looking at insurance market reform, an individual mandate requiring people to purchase insurance, and premium and cost-sharing subsidies. Now, important to remember, IHS is not insurance. So even though insurance is required to pay for things like screening colonoscopies, Indian Health Service is not required to pay for those because IHS is not insurance. In terms of the individual mandate, there's recognition that as American Indians, we have a legal right to health services, so we shouldn't be forced to pay for it. So we are exempt as American Indians from the individual mandate. On one hand, that's a great thing because it recognizes the federal trust responsibility. On the other hand, it could make disparities even worse because we'll be potentially the largest uninsured population moving forward. Now, in terms of premium and cost-sharing subsidies, we'll talk a little bit more about those because we do have some unique and potentially very meaningful provisions in the Affordable Care Act for American Indians for subsidies. So Title II is Medicaid and CHIP. Now, Medicaid programs in most states primarily cover children and pregnant women, and you have to meet the federal poverty guidelines, usually around 100% of federal poverty level. For Medicaid expansion, that was expanded to 138% of federal poverty, and it was for everyone, not just children or pregnant women, but even single men are now eligible for Medicaid expansion if the state in which they live has expanded Medicaid. So that's a lot of people now who have access to health insurance, including things like paying for tobacco cessation and paying for cancer screening opportunities that we don't have under Indian Health Service alone. So why is this important for us? Looking nationally, the rates of poverty are significantly higher, unfortunately, for American Indians and Alaska Natives. So you can see that about 2.5 times as many American Indians and Alaska Natives as compared to the white population live below the federal poverty level. And this is consistent from 2005 to 2009, high rates of poverty for American Indians. So as of 2014, so now 2 years ago, the states in blue are states that expanded Medicaid. The states in orange had not expanded at the time that this particular slide was generated. So when we look at the American Indian and Alaska Native population, are there a lot of us in Alaska, Montana, Idaho, Wyoming, South Dakota, Nebraska, Kansas, Oklahoma, Wisconsin, Maine, Florida? In many of these states, we have significant American Indian and Alaska Native population. But without expansion of Medicaid, American Indians in those states do not have access to these new opportunities. Well, since that time, if we now look at, as of January 12, 2016, we've seen some good news. Montana has expanded Medicaid. Wyoming and South Dakota are under discussion that will potentially expand Medicaid. So that's good news for the tribal populations in Montana and Alaska, which now have recently expanded Medicaid, and potentially the tribal populations in South Dakota and Wyoming will benefit as well. So we just need to keep track of state policies and state legislatures to see if they will expand Medicaid. And if they do, it's a tremendous opportunity to improve our cancer control in Indian country. Another component of the Affordable Care Act, Title IV, focuses on prevention and wellness. They had tried to establish a $15 billion trust fund for prevention activities and wellness activities. That's unfortunately been cut by Congress each year. That's kind of used as a negotiating tool for budget deals, and we do not have a fully funded prevention and wellness trust fund, unfortunately. They did include clinical preventive services in insurance plans. So colorectal cancer screening is now required. And it is related to tobacco control because smoking commercial tobacco does link to higher rates of colorectal cancer. And there's a process, so fecal occult blood testing to screen for colorectal cancer. And there are those in epidemiology and public health circles who say that FOBT is just as good as colonoscopy. Well, if you have a positive fecal occult blood test, the next step is colonoscopy. So if you don't have access to colonoscopy, the FOBT is really of no value. So unfortunately, we typically don't have surgeons and or gastroenterologists in Indian Health Service that can provide these services for most sites. And again, these clinical preventive services are now required in insurance plans, but IHS is not insurance. So IHS is exempt from the requirement to pay for these services. So just another big challenge. In terms of how we pay for cancer care in Indian country, it used to be called contract health services. Now it's purchased and referred care. And before Affordable Care Act, of course, if we didn't have access to Medicaid expansion and other revenues, we simply just run out of contract health service dollars early in the fiscal year. So there's the old saying, don't get sick after June, which basically states that we run out of money before the end of the fiscal year for referrals. So now there's additional options for health insurance, particularly in states like where I am now in North Dakota with Medicaid expansion. The challenge is we need American Indians and Alaska Natives to enroll in these new opportunities. The reason this is so important, if we look at purchased and referred care medical priorities, most of our sites that I worked with are at level 1 priority, meaning the only thing that gets paid for and referred is emergent or acutely urgent care services. So level 2 includes things like primary and preventive care services, which includes cancer screening. So in some of our sites, actually unfortunately in many of our sites in Indian Health, we will not pay for a screening colonoscopy because it's preventive care. But when that individual patient has late-stage colon cancer and is symptomatic, then we'll pay for the referral because that is emergent. And that obviously is not intelligent, it's not appropriate, it's not ethical. But those are the circumstances in which we have to operate because of the limitations in the Indian health budget. So again, another need for increased access to resources. And the Affordable Care Act does provide that. In terms of subsidies, there's basically two ways that we spend money on health insurance. One is the premium tax credit. So if you are impoverished, basically you get a tax credit, not a tax deduction, but an actual credit that will help you pay for your premiums. So the premiums are what you pay every month when you have health insurance. So up to 300% federal poverty level, American Indians should pay $0 for their premiums. Then there's also subsidies for cost sharing. So again, your premium is what you pay every month, and then cost sharing is things like copays. So when you go to the doctor, maybe they charge you $5 to $25 as a copay. You should have no cost sharing and copays, again, up to 300% federal poverty level for American Indians. Now, the premium tax credit is based on expected income, and it's determined when you enroll. And what's wonderful about this tax credit is that it's paid for in the form of advance payment. So when you sign up, if you're eligible, they don't charge you money for your premiums and then you get reimbursed with your income taxes. It's actually an advance payment toward getting health insurance. They've made it very easy to get health insurance. The challenge that we see is in states who have not expanded Medicaid, people are not eligible for much of the Affordable Care Act opportunities, including the marketplace, unless you are at least at that 138% of federal poverty, because the assumption was below 138 you'd be getting Medicaid expansion. So if your income is 138% of poverty and lower, and your state did not expand Medicaid, then kind of the new donut hole here is that people in those circumstances then quite often are not even eligible for the marketplace. So another reason why it's important to work at the state level to try to ensure that states are expanding Medicaid. Now this is very important. If we look at, for example, a family of 4, 138% of federal poverty is actually $32,913. Do we have Indian families making less than $32,000 a year? Well, in the Dakotas, we certainly have a lot of them. Now, if we look at 300% of federal poverty for a family of 4, that's over $71,000 in income a year. Do we have American Indian families making less than $71,000 a year? Well, we have a lot of families, particularly in this region, that are quite impoverished, and they do not have access to a lot of income, but they are now eligible for these opportunities under Affordable Care Act. So in terms of cost sharing subsidies, it reduces deductibles, copays, and coinsurance, so out-of-pocket spending is decreased significantly. So for the premium tax credit that's up to a 300% federal poverty, for incomes that are below 250% federal poverty level, we get cost sharing subsidies. Again, that's the copays. So for many of our people, we have significant opportunities to expand access to resources and improve cancer control with the Affordable Care Act. So one of the opportunities that exists, that if a tribe has the means and they choose to, they can purchase insurance on behalf of tribal members. And if they come from an impoverished community, they could coordinate access to health insurance through the Affordable Care Act, Medicaid Expansion, and the marketplace. And again, essentially with no cost sharing, up to about 300% federal poverty level. So tribes can decide which plan they would sponsor, and they can work directly with the Medicaid Expansion as well as the plans available through the marketplace. So why should we participate? Why is this important to us? Well, we would save purchase and referred care dollars. So the PRC dollars don't go away, but it's not enough to meet our needs for cancer care and other specialty care. So IHS tribal and urban programs could bill and collect and increase third-party dollars. So even if you have a IHS direct facility and you've been struggling to get referrals paid for, the more people that are insured, the more revenue is coming to that IHS facility, which means they could potentially redirect some third-party dollars for referrals and maybe pay for level 2 and level 3 priorities. So we should look at this as an opportunity not just to benefit the individual tribal member, which it is a great benefit, but it also can improve our entire health system. So we should be thinking of the Affordable Care Act as the largest expansion of Indian health in our generation. And it's important for us to keep in mind as we now have the opportunity to dramatically increase access to health resources. So this is taken from a presentation I've given to several tribes here in the Northern Plains, but it's applicable to other tribes who are located particularly in states with Medicaid expansion. So if we think about income, between 0 and 138% of federal poverty and 300% of federal poverty and higher. So for insurance status, if your state has expanded Medicaid, everyone up to 138% of federal poverty, again about over 32,000 per year for a family of 4. That means that everyone in that income category is eligible for Medicaid and Medicaid expansion. Between 138% of federal poverty and 300% of poverty, we're eligible for marketplace insurance at no cost sharing. So essentially free health insurance to American Indians up to over $71,000 in income for a family of 4. And then above 300% federal poverty, what we're finding is that most of us are insured if we're over 300% federal poverty, but there are some people who are at over 300% federal poverty that are not yet insured. So some additional considerations. In North Dakota, looking at our various data sets, including census data, we estimate that about 60% of the American Indian population in North Dakota is eligible for Medicaid and Medicaid expansion. Again, very high rates of poverty, but if we go all the way up to 138% of federal poverty, about 60% of our people are eligible for Medicaid and Medicaid expansion at no cost to the individual. We also estimate that between 138% and 300% of federal poverty, again, between about 32,000 and 72,000 in income for a family of 4, there's about 30% of the population eligible to participate in the marketplace at no cost, and then maybe 10% of our population is over 300% federal poverty, and most of that population is already insured. So here's the remarkable opportunity. If the tribes choose to, they can 638 or take over those funds under contract or compact and use purchased and referred care funds to pay cost sharing for those few individuals that would not have insurance otherwise. And the tribes can use those 638 dollars to expand efforts to enroll people in insurance. Now, the reason this is such a remarkable opportunity is that one of the biggest complaints about Indian Health Service over the years has been running out of money for contract health services. It's a big challenge. And in this circumstance, we could have every American Indian in a state that has expanded Medicaid, every American Indian with health insurance. So what does that mean? It means that when we go to IHS, we're generating revenue for the local health system. If we choose to and we have the means for transportation, we don't have to go to IHS. We could go to the private sector, and IHS would be in a position where they have to compete for our business. The only thing that would come out of that is improved services and improved quality of care. In addition, we should be able to start screening for cancer at an earlier stage, not just a level 1 priority, but following actual clinical guidelines for cancer screening. With this policy intervention, we should see dramatic improvements in cancer outcomes. So opportunities to consider for tribal leaders and health service providers. In your communities, maybe consider a feasibility study of using 638 contracted PRC funds for marketplace cost sharing for tribal members. And again, if your state has expanded Medicaid, and more of them are looking at doing this, the opportunity to make sure everybody is insured is just remarkable, and we should see dramatic improvements in access to things like smoking cessation medications, as well as cancer screening. Now for IHS, on our formulary for smoking cessation, we have nicotine replacement. That's typically the extent of it. There's newer, better medications that can help people quit smoking. But one of the things we need to do, particularly with tribal leaders, is to encourage enrollment in Affordable Care Act. And I was at a tribal leaders meeting a few years ago, and I was talking about the need to participate in Medicaid and Medicare. And one of the tribal leaders actually became very angry and said, I hear what you're saying, Dr. Warne, but I don't have a treaty with CMS, Centers for Medicare and Medicaid Services. And I told him, I agree, you do not have a treaty with CMS, but you do not have a treaty with IHS either. IHS is actually a relatively small component of the federal budget. And if we want to genuinely make an impact on Indian health, we need to access additional resources and services. So yes, we can participate in Affordable Care Act programs. The cost sharing is with federal dollars. Medicaid services for IHS and tribal programs are paid with federal dollars. We're using federal dollars even in the marketplace. So from my perspective, the Affordable Care Act is consistent with the federal trust responsibility. In addition to that, it's an opportunity to save lives and to eliminate some of these terrible disparities that we have. So again, I look at Affordable Care Act as the largest expansion of Indian health in our generation, and we need tribal leadership and health services providers to assist in getting the word out, but also getting people enrolled. This is also an opportunity to establish evidence-based and best practices in American Indian cancer policy or tobacco control. I'm sure many of you work in tobacco control, and CDC publishes a document called either best practices or evidence-based practices in tobacco control. And essentially none of their evidence-based practices are done in Indian communities. So my question is always, well, whose evidence is it? Perhaps with more access to services, we can start to develop our own evidence base in terms of best practices in American Indian tobacco policy and American Indian cancer policy. But we need resources to do it, and the Affordable Care Act can help us with that. So there's a potential that we could eliminate the need for purchased and referred care in some of our tribal communities. So just think about that. One of the biggest limitations in healthcare for many of our tribal populations has been limitations in contract health services or purchased and referred care. If everybody's insured, you do not need purchased and referred care. You can 638 those dollars to cover cost sharing. So all kinds of opportunities. We also need to eliminate the disparity in colorectal cancer. Again, American Indians are the only population with either flattened or worsening colorectal cancer mortality rates because every other population has access to appropriate screening. In terms of lung cancer screening, there is now, there's guidelines for lung cancer screening. It's essentially people who are over age 50 with a 30-pack year smoking history, and we have a lot of people in that category, should get a low-dose CT. Now the challenge is IHS doesn't have low-dose CT scanners or spiral CT scanners. However, this should be covered under Affordable Care Act. So again, with access to insurance, we could potentially even improve lung cancer outcomes as well. I always like to end with this photograph. It's like a picture of my mom on the left and my grandmother on the right, and this picture's from about 1990. So quite a long time ago. But my grandmother came to live with us when she was elderly, and she had been a lifelong smoker. And she's from Pine Ridge, and we were living in Arizona at the time. And she wound up getting a cough that wouldn't go away. So we took her to Phoenix Indian Medical Center, and they did a chest x-ray, and it was clear that she had lung cancer. So she was not eligible for Medicare because she didn't have her 40 quarters or 10 years of working, paying into Social Security, because she was a full-time mom and a full-time grandmother, like many of our elders are back home. we couldn't prove how long she lived in Arizona, so we couldn't get her signed up on Medicaid. And contract health services required, it still requires you to live in your CHISDA, your contract health services delivery area. She was not eligible for a referral to an oncologist, so we had to bring her back to South Dakota. We had to try to get her re-engaged in the IHS system in South Dakota and try to get a referral to an oncologist. She wound up dying in an emergency room without ever seeing an oncologist. Could that happen today? You bet it could. And the challenge is we can't allow this to happen anymore. And we have it within our power now, if we have Medicaid Expansion and Affordable Care Act, to just get people on insurance. If she had insurance, she would have been seen earlier, and it would have reduced a significant amount of unneeded suffering and early death. So I will go ahead and leave it there, and we have about 5 to 10 minutes if there's any questions or comments.
Thank you very much, Dr. Warne. And at this time, we will go ahead and start taking some questions here. We'll go ahead and wait on standby at the moment for folks that may have questions to go ahead and type them up.
And also, I do have my email address here. If people wanted to contact me directly, that's perfectly fine. Just donald.warne@ndsu.edu.
Excellent. Thank you very much. So I'm still not quite seeing any questions come up yet. All right, we have one question that says, are you available for presentations outside of North Dakota?
And the answer is yes. Please send me an email, and I'm happy to share this information. I'm originally from South Dakota, but I've worked also in the Southwest as well, so I'm happy to engage tribal populations anywhere.
Excellent. We also had another person say, great presentation, thank you. Let's see here. What are the basic steps that state health departments could take to begin working with American Indians on cancer prevention and control?
Very good question, because much of what we deal with in terms of having access to services for prevention and public health, we have to work with states, because the states get access to block grant funding and tribes do not. So we have to have a good relationship with the states. And from the state side of the equation, I think the states that are the most effective are the ones who have tribal liaisons actually working within the Department of Health. And many states have them, many do not. And each state is remarkably different in terms of how well they engage tribal populations. So ideally, it would be a priority at the state level to engage tribal populations. And if they do have it as a priority, what I've seen is that states who have tribal liaisons working within the Department of Health tend to be the most effective at engaging the tribes. So those, I think, would be good starting points.
Are non-federally recognized tribes without Medicaid expansion just out of luck?
Very good question. And for access to Indian Health Service, it is for federally recognized tribes. So with IHS, that's one of the nuances. And you know, with limitations and resources, that's been an unfortunate arena where current federally recognized tribes aren't necessarily supportive of additional tribes being federally recognized, because that doesn't mean there'll be more money in the IHS. It just means it'll be divided up further. So for non-federally recognized tribes and states that have not expanded Medicaid, that's kind of a double whammy, so to speak, because less access to IHS and less access to payers. And ideally, we'll just see more states expanding Medicaid. My hunch is that over the next several years, we will see most, if not all, states expand Medicaid. Right now, I think there's just political backlash because of feelings about President Obama, not because of the actual economics of Medicaid expansion. So as those things evolve and change, I'm hoping to see that more states will expand Medicaid.
All right, and then we'll leave it open for another minute or so, see if anybody else has other questions here. Gotten many folks that have said thank you very much for the presentation. They seem to really enjoy it. So we're happy to have Dr. Warne here to help go over some of this stuff.
Yep.
All right, I don't see any more questions coming across, so at this point we will say thank you for attending the webinar. We did have one more question come up that says, can you comment on native spirit cigarettes?
Yes. This is what's called the Natural American Spirit cigarettes, and they use imagery of American Indians, and basically it's a native person with a eagle headdress holding a sacred pipe. It's false advertising. They say things like 100% natural ingredients. They are no safer than any other commercial cigarette, and it's not a tribally owned operation. So it's not an American Indian-owned entity, and if anything, they are guilty of both false advertising in terms of saying that it's, or implying that they're safer, which they are not, and also by generating this imagery, trying to make it seem like it's an American Indian-owned entity. It is not Indian-owned, and it is absolutely inappropriate use of cultural imagery. Those are sacred images. From my perspective, it would be like trying to sell vodka using the image of the Pope. I mean, it's just inappropriate. So there's been effort through American Cancer Society and the FDA to try to change their packaging and advertising, and I think that's something we should be in support of as tribal stakeholders.
All right, and I think that also answered the second part of his question, asking if American Indians benefit, and most certainly it sounds like they do not.
Yep.
Is there anything in the works for electronic cigarettes related to laws and policies?
Yeah, actually that's going on a lot at the local level, and recognizing that you know, electronic cigarettes are dangerous. It gets people addicted to nicotine, promotes nicotine addiction, and promotes use of nicotine products in younger age groups. So that's an evolving area of policy development, and I think as tribal stakeholders and advocates, we should also be on board with trying to prevent utilization of e-cigarettes as well.
All right. And let's see here. I don't see any more questions coming across at the moment. Leave it open.
I think that takes us right to 4 p.m. Eastern, right?
Yeah, we're right there on the button, just about. So I think at this time we'll go ahead and wrap it up here. One more question: can electronic cigarettes cause cancer?
Can what now?
Can electronic cigarettes cause cancer?
We don't have enough data to say for sure either way. We know that there's significant amount of nicotine, but we don't know everything that's in them. And you know, they've been around a short enough period of time. We don't have the long-term studies, but we do know that it promotes addiction to nicotine. But I think we need more time and more studies to answer whether or not it directly is linked to cancer. I wouldn't be surprised if it is.
Okay. And at this time, we'll go ahead and say thank you for attending this National Native Network webinar. We will send a brief SurveyMonkey evaluation by email tomorrow. If you are planning to obtain continuing education units for this webinar, complete the evaluation survey in its entirety within the next week. Please visit our website at www.keepitsacred.org to find this and other technical assistance webinars, as well as many other cancer and commercial tobacco prevention resources for tribes and tribal organizations. For those that may have missed the webinar, we will also post a recording of the webinar along with the slides as well up on our website at keepitsacred.org. Again, we want to thank Dr. Warne for his time and the kindness of being able to reschedule from the January date that we had set up, and his patience with working with us on everything. And at this time, we will say goodbye to everybody. Thank you very much.